Welcome to part 2 of the episode 2 of Pulmonary Embolism series. Coming to another very important flow chart from the guideline paper. What do we do now and how do we manage a patient once we have these clinical categories? So you see, we start with category A subclinical, category B symptomatic but lower score. In these patients also, once you've seen a pulmonary embolism, you must initiate DOACs. So you must initiate anticoagulation here. You use Hestia, PESI or simplified PESI to assess their short-term risk, which means that based on their short-term risk, you can decide whether you can send them home on DOACs or you need to keep them in the hospital. And you use decision tools to identify suitability for outpatient treatment. So this happens when your patient is less symptomatic or it was an incidental diagnosis. This clinical severity scores will tell you what to do and where to keep him. Category C1 to category C3. In fact, right from category C1 till the end, we initiate low molecular weight heparin. So we have a standing on which heparin to use, low molecular weight or unfractionated, and we'll talk about it. But we initiate low molecular weight heparin. For category C's, we need biomarkers. So we measure at least one cardiac biomarker. We do measure lactate. Remember, we are going to rule out hypoperfusion and normotensive shock, which is throughout from category C onwards. We will evaluate all of them for RV size and function with RCT and or R echo. We will use validated risk scores to identify which one is high risk, and we will do a multidisciplinary PERT assessment, which we will be talking about. For categories D onwards, you have to evaluate for normotensive shock, and you may need to introduce vasopressor or inotropic therapy in case of a shock. Some patients from category D1 onwards may require systemic thrombolysis, and there are indications for it if acceptable bleeding risk. For patients who are in cardiopulmonary failure, we might need systemic thrombolysis or surgical embolectomy, and that has to be taken care of with the bleeding risk. And patients who are in occult cardiopulmonary failure, they may need a ECMO. So this is in summary one slide that tells you all that you have to do about once you see a PE patient. So none of this currently available scores alone will be able to tell you the risk of clinical deterioration in your patients, especially the hemodynamically stable ones. So this tells us how you have to use multiple variables, you have to use dynamic variables. And it's also important to emphasize here that this is an ongoing assessment. An initial assessment may not completely define what has to be done till the end. And as the patient becomes more severe, we have to look at changing the way we manage it. So with this, there have been studies like the Home P study, a multi-center international study, which talked about hospitalization or out treatment management of patients with PE. And they used simplified PESI guided instructions to identify whether a home treatment is needed or patient should be managed in the hospital. But they also saw that clinicians could follow the risk score, but a lot of time they had to overrule these scores to admit a patient based on his clinical probability. So therefore, one single score may not be enough but we have to use multiple clinical parameters to decide whether to keep the patient in the hospital or discharge home. So for my patient, Mrs. Mehta, she's in category C2, C3. She is hemodynamically stable, yet she does have an RV dysfunction. Her troponin is positive, but she is not in shock. This keeps her in category C. Now, it's important to remember that these patients between category C1 and D are the ones who are on the edge. These are the patients who are at risk of clinical decline, and these are the patients where an incipient cardiopulmonary failure may happen. So this group of patients are the one who needs most monitoring. A close monitoring within the first 24 to 72 hours is required for worsening clinical status, which was also supported by the Pletho trial. So this critical time, this patient will not be sent home. So for my patient, Mrs. Mehta, there is no way I am sending her home. She will be initiated on anticoagulation in the hospital. And because she doesn't have shock, she probably can be managed in a ward if I can do a close observation. So what is the table in the guideline? Hospitalization admission decision considerations. Grade 2 evidence. In patients diagnosed with PE in a clinic or an emergency department, it is reasonable to use a decision tool and identify patients suitable for outpatients. In selected patients with PE category A and B in a clinic or ED, outpatient treatment is a reasonable option compared with hospitalization when the rate of 90-day adverse outcomes is low and aligns with the patient's goal. So which tools are we using? We are using the HESTIA, the PESI, the simplified PESI. We are looking at patients in A or B for outpatient. Beyond that, only admission. And we are also looking at what are the patient's goals when we are deciding on outpatient. Now, this varies across regions, countries, availability of infrastructure. A Cochrane review actually compared outpatient treatment with inpatient treatment in patients with low risk PE and demonstrated that there was no difference in adverse clinical outcomes. So, there have been many studies which looked at which decision tool should I use, but they have seen a good predictability with all, including the HESTIA, the PESI, or the simplified PESI. Most studies have evaluated PESI incorporated with multiple items as exclusion criteria. And so you cannot just identify and say PESI alone is sufficient because they have used many other exclusion criteria. There's been very few and probably only one RCT which has compared the different decision tools to determine which one is better for outpatient treatment of PE. So they have seen that physician determination and a shared decision making with the patient will always override the decision tool results. So that is something one has to be very, very mindful for. So what is the guideline position on triage? Every patient with acute PE should be triaged considering following 5 domains. Number 1, clinical outcome risk stratification, which we have seen. This will tell us whether the predicted outcome is good and what is the risk of mortality. The clinical status, which will depend on the hemodynamic status and the respiratory status. Number 3, whether they will need advanced therapies, which may be catheter-based interventions, inotropes, ECMO. What is number 4? Your facility expertise. Someone may need a catheter-directed embolectomy, but do you have it? Would you want to shift him? And number 5, PERT, multidisciplinary decision meeting. And this is with a pulmonary embolism response team model. So coming back to the same flowchart, once you know which category your patient is in, you can initiate the right treatment, you can keep him in the right setup, and for that you use multiple tools along with the clinical severity scores. Remember, the decisions should be made on these 5 criteria that I just told: the clinical status of the patient, the hemodynamics, the potential need for advanced therapy, the expertise, the availability in the facility, and ideally a PERT response team should be there to assess. So, placement in the hospital, the recommendation grade 1 is that if your patient is receiving thrombolytic therapy, whether systemic or catheter directed, you would want to place them in a unit which can do close monitoring. So, definitely an ICU or an HDU. And grade 2, in patients who are admitted and undergo mechanical thrombectomy and hemodynamically stable, you can admit them in even in a level of care that can provide continuous telemetry and nursing care familiar with post procedure complications of the device. So if the patient is in a cath lab or if the patient is in a cardiac HDU, that may be a setting if your patient is hemodynamically stable. But if your patient is in a higher grade, obviously will require an intensive care unit. Regarding inter-hospital transfers, grade 2 recommendation says that if your patient has high risk features but is hemodynamically stable, C3 to D, transferring to a center which can give advanced therapy may be considered, but it will be of more harm, grade 3, where you are trying with unstable patients, say in category E, to transferring them before stabilizing. So that is a word of caution. And what kind of centers do we need? They mean to say centers with advanced imaging, centers with multidisciplinary teams, with vascular medicine, with general cardiology, hematology, interventional radiology and cardiology, cardiothoracic surgery, vascular surgery, amongst others. For these patients, this may be required, but the decision has to be very, very careful because you would do more harm in trying to transfer an unstable patient. So, what is this PERT team that we've been talking about? PERT team is a PE response team, and this team includes those members which can ensure risk stratification, which can give insights from the specialities, which can help select the use of advanced therapy, implement evidence based protocols, educate the peers, and give training and have better pathways. So, this high functioning PERT in any hospital can impact the clinical care of patients with PE, and it will be the most appropriate to take advanced decisions and interventions to reduce mortality and reduce the hospital length. So that's really, really important. The possible members in a PERT team may include a pulmonologist, critical care specialist, a cardiac surgeon, a non-interventional cardiologist, radiologist, both interventional, non-interventional, vascular surgeon, hematologist, ER person, nursing team, pharmacy, and yes, the patient's family also. For Mrs. Mehta, the emergency physician has seen her, followed by a pulmonologist, a cardiologist, an interventional radiologist, a cardiac surgeon, and the ICU team. And together they may form a consensus on the next approach. So, PERT teams will be really, really helpful and play a significant role. Now, this is an example of a PERT activation where a patient presents with an acute PE. Once an assessment, history, physical labs, and imaging is done, we divide A, B, C, D, E like our clinical categories. For A and B, we initiate anticoagulation, managed by the primary team and outpatient follow-up. But for C, D, E, PERT is activated, a multidisciplinary involvement is done, and then assessment and follow-ups are done. So for Mrs. Mehta, now our patient is in category C2, hemodynamically stable. What should we do next? We have her in a hospital. We're going to monitor her for deterioration. So the recommendation says that if your patient has acute PE and does not have an absolute contraindication to anticoagulation, anticoagulation therapy should be initiated to reduce the risk of recurrent thromboembolism and death. So, anticoagulation must be given, but please rule out the absolute contraindications. Also, grade 1, in patients with acute PE who require parenteral anticoagulant, low molecular weight heparin is recommended over unfractionated heparin to reduce the incidence of recurrent thromboembolism and major bleeding. So, one, do anticoagulate. Two, give LMWH preferably. The next is that for patients who are eligible for oral anticoagulation, DOACs are recommended over vitamin K antagonists unless contraindicated to prevent recurrent thromboembolism and reduce major bleeding. So we would prefer them if you are having a patient eligible for oral anticoagulation. And grade 2 for patients with suspected PE in category C2 or high, where the bleeding risk is low, it may be beneficial to give therapeutic anticoagulation when imaging is delayed or not immediately accessible. So this gives room for doing an emergent thing when things are getting delayed. For my patient, in case it's difficult to get an imaging done, but I know she has a high intermediate risk of having PE and this patient has a low bleeding risk, one may have to consider administering therapeutic anticoagulation in certain settings, but a grade 2 recommendation. So, coming back to our patient, 6 hours later, she's in the ward, and now her BP falls to 108 by 68, heart rate 118, respiratory rate higher. She's on oxygen, but her SpO2 is 91. Should she stay in the ward? She would probably move to the ICU. Why? Because admission is not a one-time decision. Remember, these patients with category C specifically will need serial reassessment because deterioration can occur within first 24 to 48 hours and up to 72 hours according to the guideline. So my patient who was in category C2 with intermediate risk has a positive troponin telling me she has a higher short-term risk. She has RV dysfunction, so she's under close observation. And though she was hemodynamically stable, no immediate reperfusion was indicated. Now she is having a drop in BP and a drop in oxygenation. So we have a respiratory modifier because she is on oxygen. Now she would be moved to, yes, the answer should be an ICU. So now my patient moves up the ladder to another risk category and she's now in category D. 4 hours later, her BP is 94/66, her heart rate is high and her lactates are gone up. Remember, normotensive shock? This patient's lactate being higher, this patient having a falling blood pressure, this patient now moves to my next category. So does Mrs. Mehta now need a thrombolysis? Look at category D. You are on LMWH. You have to evaluate for normotensive shock, which is existing in this patient. Now, if needed, vasopressors will be given, but systemic thrombolysis is now a good alternative if acceptable with the bleeding risk. She's in category D, her lactates are high, her cardiac markers are high. Should she be thrombolized? PE is dynamic. Remember, the decision making will evolve as the patient's condition will evolve. So why would she not be considered for reperfusion earlier? When she was in category C2, she required no thrombolysis. But now in category D, we have to consider reperfusion because although she doesn't have a persistent hypertension, she does have a normotensive shock. So going back to the same flow chart, this patient now is a candidate for systemic thrombolysis if not contraindicated. So systemic thrombolysis will be our first choice when indicated. Catheter-directed thrombolysis would be considered for specific group of patients where you can actually have a larger thrombus burden which can be managed with the catheter, where there is concern with bleeding with systemic thrombolysis. Mechanical thrombectomy, again, when you need to break the thrombus, but there are contraindications for systemic thrombolysis. Surgery may be needed in certain patients, and as the patient worsens, VA ECMO may be a bridge therapy. So what do we say about hemodynamic pharmacotherapy? Grade 1, for patients with cardiogenic shock, so we are moving to category D2 and E. For patients with cardiogenic shock, the use of vasopressors and inotropes is recommended to improve the cardiac output. And grade 2, for patients in category D to 1 to 2, where there are concerns for reduced preload based on the clinical assessment, volume management with normal saline and other volume expanders may be considered. So as I said, you can give for transient hypertension an initial bolus 500 to 1000 mils of normal saline. You may try for response to volume therapy, but if the patient seems to be worsening, the use of vasopressors and inotropes is recommended. Grade 2B, for patients in category C2 to E, the use of inhaled pulmonary vasodilators may also be considered to reduce the RV afterload. But grade 2 exists. Now talking about mechanical circulatory support. Now the guidelines don't give a very dedicated table about indications, contraindications of vasopressors or thrombolysis or anticoagulation, but we remember that any decision regarding systemic thrombolysis has to balance the potential benefit against the bleeding risk and the clinical context. So by that, for mechanical ventilatory support also they have given recommendations. The grade 1 recommendation says that if this patient is now a known PE on VA ECMO, continuation of peripheral systemic anticoagulation is recommended in the absence of a bleeding to prevent thrombotic embolic complications. So no bleeding, with close observation, continue the systemic anticoagulation on VA ECMO. Grade 2, if the patient has a refractory cardiogenic shock because of this P, it's reasonable to institute VA ECMO provided appropriate resources are available. 2B, for patients in category E2 placed on VA ECMO, usefulness of additional advanced therapies is not well established. Talking about sedation, the grade 1 recommendation says that those who require sedation for intubation or support, that should be available to support the patient. Grade 2A, for patients with acute PE and hypoxia who are not ventilated, obviously, the use of heated high flow nasal cannula oxygenation rather than a standard nasal cannulation can be beneficial. And this is something which is really important, because if your patient is still not there, still not into frank respiratory failure, HFNC may be helpful. 3. Harm. In patients with acute P category C2E, deep sedation and mechanical ventilation should not be performed unless clinically indicated to avoid a hemodynamic collapse. So a very good critical care support is important. Now coming to systemic thrombolysis, the recommendations say that in patients with P with category E1, E2 and acceptable bleeding risk, systemic thrombolysis and anticoagulation is reasonable over only anticoagulation. So some patients with more severity category E will preferably need both compared to just anticoagulation. Coming down a category D1 to D2, the recommendation says that again, when you are considering advanced therapy, systemic thrombolysis, anticoagulation together may be considered for group D. Then for category C3, again, systemic thrombolysis and anticoagulation is preferred over anticoagulation alone. So category C3 onwards, you can do systemic thrombolysis. For patients treated with systemic thrombolysis, lower dose may be considered. And this comes from certain RCTs which have looked at systemic thrombolysis in a normal dose and a lower dose. And they have seen that even patients with a lower dose rather than a standard dose RTPA, 100 milligram 2 hours, standard dose versus 50 milligram, even patients with a lower dose, 25 to 50 milligram of alteplase compared to this standard have been found efficacious and reduced risk of major bleeding. Even a dose as low as an extended infusion of 25 milligram of alteplase have been seen to be safe and effective. The guideline has not given its own dose recommendations, but definitely the paper has mentioned that low dose has to be considered. And harm if in patients with category A1 to C2, you should not use systemic thrombolysis over anticoagulation alone because there's a risk of major bleeding. What are the thrombolytics which are acceptable? FDA approved streptokinase, urokinase, and alteplase, of which streptokinase, urokinase are usually lesser available and alteplase is used the most, with the standard dosing of 100 milligram in 2 hours. So now what if my patient did not was contraindicated for thrombolysis? The other options, which we'll discuss in the episode 3, are advanced thrombolytic measures. So let's follow Mrs. Mehta till now. She came, she was diagnosed, categorized as C2, observed in the hospital, found to have higher biomarkers. Her BP falls, she was moved up a category, and now thrombolysis is next due. So 5 things one should remember. Treat the patient, not the clot. RV function determines prognosis. So echo is indispensable. PE is dynamic. Keep monitoring it. Reassess during the first 24 to 72 hours. And thrombolysis, according to the guidelines, is for carefully selected patients. So while Mrs. Mehta has survived her acute PE, she finished with the treatment? In episode 3, we'll answer the next crucial question. We'll answer for how long she needs anticoagulation, who needs lifelong therapy, and how do we detect chronic thromboembolic pulmonary hypertension. So for all of that and more, let's follow Mrs. Mehta through episode 3 once she's discharged on anticoagulation, and now the decision has to be made for further follow-ups. So with that, I will see you in episode 3 of my Pulmonary Embolism Guideline series. Till then, keep reading, do subscribe, like, and share it with your colleagues, and let's all manage pulmonary embolism better. Bye and have a good day.